This video presentation is about shoulder pain, how to make the diagnosis. I am Mayor Lloyd, Ireland, with the Department of Orthopaedic Surgery and Sports Medicine at the University of Kentucky, and it is with pleasure that I show you these slides, many of which are cases that I've taken care of over the years in my orthopedic practice. Shoulder pain algorithm. Our academy has an algorithm of how we work up shoulder pain. I think it's very important to, if you're a general practitioner, physical therapist, athletic trainer, understand the shoulder, understand shoulder exams, and probably consult an orthopedist, sports medicine, primary care physician prior to doing an MRI scan. So the imaging that we do and that has been recommended is plain films. We make the diagnosis by history and physical exam and the plain films. We institute treatment. We re-examine the shoulder, give them time to get better, and then special imaging studies are done not at the initial visit but later on. The exception would be an acute anterior dislocation, or if you thought there was subscapularis involvement with significant weakness about the shoulder and an acute injury, then you could consider doing an MR imaging earlier, or certainly if you have a fracture or some significant bone issue, then a CT scan would be So in the shoulder pain algorithm, the initial imaging that is suggested is a true AP in 0 degrees external rotation, a lateral view in the scapular plane, and an axillary view is again a very good image. Sometimes you have to hold the shoulder if they're dislocated. You as the physician have to hold the shoulder and assist the x-ray tech. Appropriate plane x-rays need to be obtained in acute shoulder injuries, and they need to be two different planes, an AP and a lateral view. More sophisticated imaging, such as shoulder MR, ultrasound, or arthrography, are not indicated in an initial evaluation and treatment of a patient with shoulder pain. It's unbelievable how many times we see patients come in with an MRI scan that might be a poor scan and no images. And certain things such as fractures, tumors can be So this is our imaging of a routine AP view shown on the left in A, and then a true AP of the shoulder shown on the right. So you should have the anterior and posterior glenoid rim superimposed on the right. These are the positions for these views. AP view in internal rotation is as shown. This is the Stryker notch view, which I find very effective in looking for a inferior glenoid exostosis, such as in a Bennett's lesion, a thrower's exostosis. Look for AC arthritis. Look for osteoarthritis of the glenohumeral articulation with spurring in the inferior aspect of the glenoid. The outlet view in this case is done supine. You can also do an outlet view standing, and this may give us a little more information about the position of the humeral head and whether it's proximally migrated, such as in a massive cuff tear. If you're doing it in a standing position without the patient supporting their arm, it might be migrated proximally, the humeral head. So you can see this is actually a lateral view that would suffice in an acute situation to know the shoulder is located. This is the upright view, so you need to know what you've ordered and what your routine series is. So this is the upright lateral view, and standardize your views. Get views that you're comfortable with and know the position of the patient. So this is a outlet upright view. Humeral head should be dead center on the glenoid. This is our usual axillary lateral view in neutral palm position, shooting 90 degrees to the shoulder. And this is our modified view, which with a humerus and external rotation can show a Hill-Sachs lesion or a posterolateral humeral head impaction compression fracture. Glenoid as seen, but see the sloping of the posterior aspect of the humeral head in the X-ray in the upper right.